Thanks everyone who's here at the moment for coming to the first InnovaSpace Journal Club, or the Space Journal Club, hopefully the first of many that we plan to run over the next few years. To provide a little bit of context, so my name's Lucas Renberg. I am a medical doctor in England. I work at Southampton. I'm an intensive care and anaesthetic doctor in the UK. I'm currently doing a special year out with a particular focus in point of care ultrasound. And when I'm not at the hospital, I have a few other hats that I wear. So I've worked with Thais for many years, and I sort of work with her through her sort of outreach with InnovaSpace and part of the Space Crew initiative. I also work as one of the medical officers, or the chief medical officer, at the Austrian Space Forum, so a group based in Innsbruck in Austria that runs Mars analog missions every few years. So I've been working in and around space medicine, physiology, space life sciences for the best part of 10 years, very much inspired by Professor Usmana herself, very much been a guiding hand and a mentor. So through her inspiration, through outreach that she does across the world, this is of my small contribution to that. So this is mostly aimed at sort of medical professionals, but there's no reason that anyone with an interest in space life science can't join in, listen, learn, partake in discussions. You know, space is all about the multiple disciplinary team. No one person can get anyone to the moon and back. So it's, yeah, I encourage everyone to join in for the discussions afterwards and for the journal club in the future. For this first one, I've decided to take quite a big paper back in 2019. And what I'm hoping to do over the next sort of hour is take the first 30 minutes, just do a critical appraisal of the paper itself. So this is sort of fairly standard stuff for sort of medical students, doctors. You know, you often read research papers, reviews, and we take them apart and examine the methodology, the research question, the results, statistical analysis, and the discussion, and have to think, how clinically relevant is this to my patients? How can I apply this to my practice? Will this change what I do? So hopefully I'll spend the first half of this session talking about that. And then hopefully the more fun part maybe would be the discussion afterwards. You know, this paper in particular is particularly unique in finding a new pathology after more than 50 years of spaceflight. So hopefully there'll be plenty of discussion afterwards. And again, my focus really is thinking about worst case scenarios of intensive care. Planning for the worst is often sort of what we do in anaesthetics and ITU. And so if we plan for the worst, then hopefully we cover all our bases. But obviously, with the caveat of working in a resource limited environment like, you know, space, microgravity, International Space Station, you know, and even sort of further on sort of an exploration class missions. So me and Thais will sort of share that, but I do really encourage people to put questions throughout in the message area, but also just to join in the discussion. You know, it's open to everyone. So the paper we're going to talk about, 2019, was a journal that was released in the Journal of American Medical Association, and it documented sort of static blood flow in the internal jugular vein of some astronauts that have been flown in the International Space Station, and also documented the first ever thrombus as well that have been documented during spaceflight. With any appraisal, you always have to look at sort of the source of the journal. So JAMA is a fairly well-known journal throughout the States, and internationally it's got a fairly decent impact factor. It's not necessarily the best metric of how good, in inverted commas, a journal is, but you know, an impact factor of 30 suggests it's being cited, you know, more than 30 times a month. It's a pretty good impact factor, so you can tell this is a reliable, open access, peer-reviewed journal. So it's from a credible journal to start with. And the things that caught me about this when I first sort of read the paper a few years ago was exactly that. I know there's lots of unknowns in space flight and space physiology and space medicine, but this was just the first new pathology. There's lots of research around SANS or space flight associated neuropathy syndrome and a few other pathologies that are particularly of high importance and significance when you're thinking of sort of roadmaps for exploration missions. But this was the first ever documented venous thrombus in an astronaut during spaceflight. And with that come the implications of how do we screen, manage, how do we treat these going forwards if we're now thinking of longer duration missions. So for me, it was pretty exciting. And then also sort of threw up a whole set of new questions of, as I said, how do we screen for this, monitor this, how do we treat this, worst case scenarios. So this is what I found really interesting. So when we sort of look at the paper, I always start at sort of the title, the journal, and then also look at the authors. So this is just, there are many different styles of critical appraisal. This is just my style. And a whole list of names which can get lost in there. But looking at their affiliations and recognizing some of the names from various journals and papers over the year, you realize that these are all individuals with expertise from multiple different space agencies across the world. And in particular, I've just, I'm playing favorites, but I recognize immediately these 5 names that I've underlined. These guys have been publishing in space life sciences for a couple of decades. Particularly, I'm aware of sort of Scott Dulczewski. He's one of the individuals who very much pushed point of care ultrasound in space, and very much got the machines up there, initiated a lot of the primary research, and has also sort of translated that to telemedicine and teleultrasonography back on Earth. And this is all NASA funded human research program, part of a multi-institutional sort of fluid shift study. So again, credibility of the journal, credibility of the authors. So already this paper has got a fair amount of credibility behind it. And I think this is really, really important, as I touched on, for the whole space community, because it's a new pathology. And with so many open-ended questions, it really needs the resources of multiple different lab institutions, space agencies to really come together to have a shared knowledge, to problem solve, to troubleshoot, to come up with new novel ways of treating this, monitoring this. So I think it has massive implications for the whole space medicine community. And then also, one of the sort of secondary outcomes or aims of the paper was also to assess the lower body negative pressure sort of countermeasure that the Russians have in the International Space Station. So it was really maybe got missed with the headlines, because there was lots of excitement about this paper. But one of the important things was also the efficacy of the lower body negative pressure device in sort of treating static venous blood flow. So primarily this paper set out to sort of take a cohort of astronauts and look at venous blood flow, or venous drainage, for like the cerebral venous outflow. There's been, ever since the beginning of human spaceflight, there's been a knowledge of fluid shifts, often described as puffy face, chicken legs, this fluid redistribution causing, in part, space motion sickness. And as you can see sort of on the picture on the right hand side of how this fluid is shifted, because you no longer have that hydrostatic gradient, so you don't get this variation from sitting and standing. You very much have a uniform distribution of fluid. Well, initially you have this headward shift, and then this uniform fluid distribution as you sort of diurese and lose body fluid. And this was often related to, as I said, space motion sickness, orthostatic intolerance, and returning back to Earth. But then more recently, it has sort of been linked with sort of SANS, this spaceflight associated neuropathy syndrome, and that potentially this reduced venous drainage from the head could possibly play a part in static flow. But then there's also the concern that static flow in healthy or unhealthy patients or individuals can also lead to a prothrombotic state and potentially increase your risk of forming a clot. So there has been some studies in this before. They've scanned necks and internal jugular veins, but they've never specifically looked at sort of the left internal jugular vein. So you've got left and right as you drain out of your head, and they're the main conduits that then join together to enter the right side of the heart and sort of form the venous drainage to re-enter sort of your circulation. So that was their first aim, was to characterize the venous outflow in the left internal jugular vein, compare that to Earth, but then also to evaluate the effect of the lower body negative pressure system on improving cerebral venous outflow. So I've touched on this a couple of times, but in my mind, and again, this is my opinion, it's not medical advice, this is just my interpretation of the data, but I think this is sort of a super important question. You know, human physiology is not sort of isolated systems, particularly in spaceflight. Everything is integrated. There's no sort of one set mechanism. Everything overlaps and interacts. So yes, it's about stagnant blood flow, which increases your you increase your risk of thrombus formation, and this has massive implications, particularly in intensive care of people who are developing deep vein thromboses, pulmonary embolisms. You know, the knock-on effect on their physiology, their health, their performance, and how that affects individuals and the crew, resources. But then also thinking forward of, you know, the effects of radiation, endothelial damage. I believe this research question is super important. It has massive implications, not only now for low Earth orbit and crews and ISS, but also has potentially massive implications for exploration crews, Artemis missions back to the moon, and going on to Mars, because then you have to think how all systems in the human body, all physiology is integrated, and you think about the risk of, just one example being radiation and endothelial damage. Then suddenly you've not just got static blood flow, but you've also then got endothelial damage, and then suddenly you become very prothrombotic, and then increases your risk of thrombus formation. And this has implications on SANS as a potential mechanism, but as well as crew performance as well, because then you're suddenly thinking if someone had a DVT or a pulmonary embolism, that's going to have a significant impact on their physiology, how they can function. Suddenly a member of the crew is not working, and that has a knock-on effect to sort of mission success as well. So we go to the next slide. This is just to show those who may be early on in their medical career, or medical students, or who aren't necessarily medics themselves, that when we talk about thrombus formation, we often talk about this triad of being hypercoagulable. So that could be things like having cancer, smoking, having trauma or an injury, static blood flow, slow blood flows. You know, sitting on airplanes is always the common example people think of, sitting down for a long time, breaking a bone, lying down, being in bed. Often, you know, one of the big risks in hospitals. But then endothelial damage, so again, this is things like trauma, sort of cancers, but also things like radiation can play sort of a part in that as well. So we talk about this triad, and particularly like all three of these, that's sort of the perfect recipe for clot formation. So we go on to the next slide. Onto the sort of the study itself. So they were looking at static blood flow sort of in these internal jugulars, and whether this there was in fact static blood flow in the left internal jugular. So they took a group of astronauts and did a prospective cohort studies. They took a group of patients that were the same, similar demographics, similar states of health, and in similar situations. Here are well-trained, healthy astronauts who spent a similar amount of time in space previously and on similar duration missions, and they followed them up over a similar period of time. So these astronauts were similar in many ways physiologically, but also similar conditions. So a well-matched group, and they were followed sort of over time, and they had the same interventions roughly at the same time. So 9 males, 2 females, and as I put there, so they had a mean time in space of about 210 days, but this varied between sort of 150 and sort of 300 days. Next slide. And what they did was, it was all sort of ultrasound guided, in that there was ultrasonographic assessment of the left internal jugular vein.
They did this roughly 50 days before the missions, seated, supine, and then 6 degrees head down to 150. If you read the paper, there are some variations. So it varied around plus or minus 20 days of either side of that as well. And then each at day 50 and 150, they would do it with and without the lower body negative pressure, the LB&P box, with a pressure of 25 millimeters of mercury for about an hour. In addition to this, they did take all baseline data, so heart rate, blood pressure, as well as doing echocardiograms or echocardiography or echoes, often we say in the UK, where they did take a baseline cardiac output, stroke volume, as well as looking at left ventricular function. And this is all guided by experts on the ground as well. So they were obviously, astronauts did the point of care ultrasound, but throughout they always had 2 expert sonographers or radiologists guiding them throughout. And the picture in the bottom right was a particular technique called vein press. So a technique often used to look for compartment syndrome in the lower limbs, but it's been adapted to look for pressure in veins as well. But it essentially involves a balloon on the end of an ultrasound probe, and then you to allow the ultrasound to travel through it, and then you compress the vein to a certain pressure, and it can measure that pressure. Then you can indirectly measure the venous pressure in that vessel. So it's quite a clever, non-invasive way, because we can do it evasively in intensive care, but this is a very clever, non-invasive way of doing this in space or resource-limited settings. Next slide. So the primary outcomes from this were that out of 11 crew members, 6 of them, so over half of them, showed stagnant or retrograde flow in the internal jugular vein, or the left internal jugular vein at day 50. And then this is when they picked up that the one crew member also had an occlusive thrombus in the left internal jugular vein. Important to note that after this, there was no more data collection for that individual, because he then needed to undergo treatments. There was also a lot of discussions, and he started anticoagulation therapy, so he was no longer part of that study, and he was withdrawn. So the data from after day 50 essentially is just from either 9 or 10 astronauts there. And there was also, which I think is, I've missed out on that slide, which I've added later, was that there's also, compared to the seated baseline data, there was an increase in internal jugular area and pressure compared to seated back on Earth, so back compared to their baseline. If you go to the next slide, I think it should be a demonstration of how they measured retrograde flow, which I've probably put in the slide before. So again, for anyone who's not familiar with these or waveforms or patterns, if you think of, so these are graded 1 to 4, which is a system they developed. So it's not necessarily an internationally recognized system, which is important to note. So if you look at them individually, there's a yellow line at the top. That yellow line you can think of as no flow. Anything below that, you can think of as blood flow towards the heart, and anything above that yellow line is blood flow back to the head or away from the heart. So grade 1 is normal. What you want is you want blood flow coming out of your head through these internal jugular veins back towards your heart. So all the white is blood flow that's going towards the heart, and it varies with respiration. That's why you see that wavy pattern every time you breathe and breathe out. There's variation in how quickly the blood flows to the right side of your heart. Grade 2, then if you look, there are small bits where there's actually blood flow back towards the head. Then if you look at the bottom 2 boxes, grade 3 and grade 4, this is what they define as the retrograde or stagnant blood flow. Because now if you look at the white, there's equal amount of white in grade 3 that's going back towards the head and towards the heart. So this is stagnant flow, so actually blood flow that's going back towards the head at some point and equally going back towards the heart. And then grade 4, obviously the worst in this scale, that if you look, the majority of above the yellow line, that suggests that the majority of the blood flow is either going back, either stagnant or going back towards the head, and only brief moments of actually flowing back to the right side of the heart. It's also important to note that there are lots of other small veins, right internal jugular left, and other small veins that drain out of the head. But these are the biggest ones that drain out. But this is what they mean by stagnant or retrograde flow. So that's just another important factor. So this is a unique sort of grading system that they developed for this sort of study. So it's not necessarily sort of internationally recognized, but it's been approved by multiple expert sonographers and radiologists. Next slide, please, thanks. Oh, that's just me highlighting it. And then this is sort of the big headline. So on the left, you have the longitudinal view of an internal jugular vein. So there's lots of tissue, but the black line or the black tube across the middle is your internal jugular vein, and an ultrasound, anything that's black tends to be fluid, as ultrasounds travel well through it. And again, that line below just shows that there's normal blood flow through it, like everything's below the yellow line, so it's all going back towards the heart. Whereas on the right, totally no flow, completely occluded, and there's no black there. As you can see, it's all just the same grey, white, black. It's all homogeneous there. So that's the thrombus that they found. So if you, next slide, or next, probably should be a red circle that comes up. There we go. So that's what I'm talking about, black, and then totally occluded. And then not to miss, so that was the big headlines, but not to miss the important secondary outcomes. The LBMP was used, 9 crew members used it. As I said, one that had to drop out, said thrombus. There's 17 sessions. About 60% of these showed improved blood flow in the left internal jugular vein. That's to say that still 7 of them showed equal or worse. So the LBMP box showed some improvement and potentially good as a countermeasure to help improve cerebral venous outflow, but it never returned back to baseline. So yes, it's good, but it's not as good as being sort of back on Earth. And there's always a risk benefit with the lower body negative pressure because it sort of draws venous blood flow out. So there's always the risk of causing syncope, but in this case, there was no syncopal episodes recorded. So I'm not going to go through all of this. This is just to show everyone that they did do a significant amount of data collection when it comes to blood pressure, heart rate, stroke volume. So yeah, so they did lots of echo studies, and they showed a slight drop in a few parameters. There was an increased sort of cardiac output in flight, an increased sort of stroke volume and heart rate, but there was nothing significant in terms of sort of changing physiology. So there's no syncopal episodes that was sort of related to the lower body negative pressure. So the authors were very sort of honest and very good. They discussed their flaws, potential biases and limitations of the study. One thing that's common to all human space life sciences research is the lack of numbers. There are just not that many people to choose from. There's a very limited sample size, which is common to all studies in space. It's not the same as doing a random controlled trial back on Earth, where you can have multinational studies with thousands of patients with significant statistical power to prove your research question. Unfortunately, we're limited by the nature of human spaceflight and International Space Station. A sample size of 11 is difficult to draw a firm conclusion, and sometimes you can overestimate your value, and your statistical power can be quite low as a result. Non-invasive measuring is never quite as good as invasive measuring, so often these devices can overestimate values, so in particular sort of the internal jugular surface area and pressures, and they only assess the left internal jugular vein. So there has been some studies on the right, and they have shown stagnant and retrograde flow, but they've never shown thrombus formation. So this adds to the literature saying that you do get stagnant blood flow in the left internal jugular as well as the right. This is the first time there's been a thrombus picked up, but they haven't assessed the lower limbs. They've not looked at DVTs in the lower limbs as well, but this is, I think, is subject to ongoing surveillance and research. And there's a huge number of variables as well. Yes, there's a prospective cohort study. Patients were matched, or astronauts were matched. They're a similar group, similar situation, but there's a huge amount of variation over 150 days in spaceflight when it comes to exercise patterns, other research protocols, EVAs. They became unwell, trauma, diet. So there's a huge number of other variables that can play into thrombus formation, and not just microgravity itself and static blood flow. There's all these small things that could have played a part in increasing that individual's risk to having a clot formation, which you can't account for or you can't sort of offset. So it's difficult to say it was purely static venous blood flow that caused the clot, because this individual could have done several EVAs, they could have not had much to eat and drink, they could have been feeling sick, they could have vomited a lot. Lots of all these small things could have just predisposed them to having a clot formation on that particular day. And I think this is really applicable, despite all the limitations that I potentially mentioned there. I still think this is really relevant because it's a study done on astronauts in space. It's not done on fit, healthy individuals in analogues such as, dry immersion or head down, 6-degree head down tilt studies. They are done in the same conditions in the same patient group who are fit, healthy, heavily screened, don't have any comorbidities, don't smoke, those sorts of things. So it's very difficult with a small sample size to draw definitive conclusions, but in this case, it's very significant pathology with potentially significant implications. So it'd be almost irresponsible of any sort of scientist or doctor that's part of international space programs to ignore this. We have a duty to our patients, to future astronauts, to investigate this and to screen for it and come up with clever ideas to prevent it, and how to manage it should the worst happen. And often space experts will conceive this at space medicine, and we often talk about evidence-based medicine, and often in space it's the best evidence we have based medicine, and then it's just augmented with expert opinion, advice, and discussions with other international space agencies. They do the best with what they have with the limited data and resources available. So that's sort of my interpretation of the paper. As I said, I have got some experience. I'm by no means an expert, and this isn't sort of medical advice, but I think this really relevant paper that highlighted a new pathology, which shone sort of a light on something that probably needed more investigation and more research into, specifically screening, ongoing surveillance. Do we monitor more vessels, but then also thinking about treatments as well. So I think I have it on the next sort of 2 slides ahead of how they ended up treating this and sort of the delays in treatment, potentially because of finding a new pathology which they didn't expect to find. So they detected a thrombus, but they did have discussions, and to be fair, they started very quickly, and they started a medication called enoxaparin, which is an anticoagulant very commonly used in most hospitals, particularly in the UK. So they didn't necessarily treat the clot. This medication doesn't break down clots and get rid of clots. It simply prevents new clots from forming. So that's a really important thing to mention about sort of enoxaparin and in blood thinners, that it doesn't get rid of clots that you already have. So this clot already still runs the risk of moving from where it is to then potentially going to the lungs and causing a pulmonary embolism. But they started that within 24 hours after long discussions with lots of experts back on Earth. But suddenly this patient is then using this medication once a day, every day, of limited supply. And it took them 40 days or 43 days before they brought up a new medication, something called apixaban, which is an oral version of this sort of drug, where it thins your blood, so it's an anticoagulation to help prevent clot formation, but doesn't get rid of the clot. So there was a sort of significant delay in getting that. The medication was used up over sort of 43 days. Obviously takes resupply times for it to come up. And then they continued this for sort of another 90 days. And then they withheld it 4 days before landing. In terms of risk benefit, they wanted to reduce the risk of suffering a trauma and having a significant life-threatening bleed. So the risk benefits was that they'd stop the blood thinner before returning back to Earth and going back through re-entry, just in case they suffered a trauma, because bleeding while on this medication could be life-threatening, and their chances of surviving that very limited in the context of landing and then getting back to a hospital. So the limited resources they have, the limited stock of medication you have on board as well, when it comes to any spaceflight mission, whether ISS or whether you're on your own going to Mars for sort of 18 months. So future implications, I won't talk too much because I think then it opens up to discussion. But if you go to the next slide, Dice, just the things I think about when it comes to this paper and the implications is that this isn't necessarily evidence-based decision making. These experts made the best decision for the patient they had in the resource limited environment they had. Either they started the medication which they had on board to help treat, which was very commonly used in the hospital, but they had to reduce the dose after a certain number of days to extend the duration of it. But this individual is also using individual needles and syringes every day. So they're using 40 needles and syringes every day, which is taking away from the stock of treating other astronauts if they were to become unwell. Then use resources to bring up, resupply the EPIC span, and then you're using medication, often indefinitely, depending on the cause of it. Then they were guided by experts, but if you're halfway to Mars with a 10, 15, 20-minute delay, or there's a solar flare, no radio communication whatsoever, you'd have to do all this imaging by yourself, using the ultrasound yourself. And then you have to think of the bleeding risk as well. They did, and that's why they stopped it before going on re-entry. But what do you do in this case? Do you stop this individual doing EVAs? Do they stop doing exercise? Do you then, this has a significant impact on that individual, the crew's performance, but then also potentially their mental health and well-being, because they feel they're no well-functioning member of the crew because of what they have in the blood thinner, then that may affect their overall mental health and performance. They may not feel valued as a crew member. So it's maybe going down that rabbit hole, but there's things to think about. So I think that's mostly everything I wanted to say. I think on the next slide, Tice, is to highlight that there's been lots and lots of discussion. So these are 4, I think, really relevant papers by some big names who are involved in the primary research of ongoing, more research that they've done, but also discussions and systematic reviews of the data of the fluid shift studies on sort of right and left internal jugular vein and risk of thrombus formation. So I would highly recommend, if you're interested in this topic, to read these because they've got really insightful sort of discussions about how to move forward in all of this. And I'm happy to send the links out to all these papers. They should be all open access, free to download as well. So that's the end of my part of the talk. I would say I'm more than happy to be contacted about any of this, whether you want to ask questions about this, future journal clubs, space medicine, or anything in general. If you want a certificate for attending today for the talk and discussion, if you use the QR code and scan it on your smartphone, that'll take you to Google Forms. And if you fill out the Google form, you'll get a certificate for attending the course. I'll also put a Google link in the chat as well, so you can click on the link as well. So I think that's about it. There is another slide afterwards. If you want to go forward, Dice, so press once more. Oh, so the QR code is in the top corner, so you can still use that QR code and scan that and fill in the feedback. It'd be much appreciated. This is the first journal club, so it's always nice to know what you think and how it can improve for next time. But then these are just some potential discussion points that I thought we could, to spark some debate and conversation. But otherwise, I think you guys have probably all had enough of listening to me. And I'm happy to sort of take any questions if anyone wants to ask me or Tice anything.
Thank you very much, Lucas, for the talk. It was really, really interesting. The first thing I wanted to ask about was, you mentioned EVA earlier, and can we talk about EVA as in a risk factor for increased chance of trauma and then bleeding, or do we have to worry about it with thrombosis as well?
So when I think about it in the terms of a trauma. So EVA increases your risk. Now these guys, when they do EVAs, it's not uncommon to bash up a finger, get a sprain, a piece of kit goes flying and hits them. Then there's always the risk, they've got very strict rules, but there's always the risk of barotrauma as well, going from one atmospheric pressure to another, to an airlock, then in and out, loss of pressure in the suit. So all these things increase your risk of trauma, and trauma is really bad in terms of your coagulability and your coagulopathies. So every time you cause trauma, you damage endothelium, you open blood vessels, and suddenly you activate clotting cascades. Obviously it's a survival mechanism, but the moment you cause trauma anywhere in your body, you're going to promote and be prothrombotic. You're going to activate clotting cascades. And suddenly if you add in static venous blood flow in a microgravity environment to a trauma, when your body's then hypercoagulable, suddenly you've got the 2 out of the 3 triads. And then it's these individuals. I see it quite regularly in intensive care. You can get your fit, healthy 21-year-old who's broken their ankle playing football. They come in, they have a cast, they're in bed for 3 or 4 days waiting for their operation, and they can get DVT, they get a PE, life-threatening, life-changing conditions. It's very rare, but it does happen in this population. It doesn't seem like much, but damage your finger, break a bone, break a finger, hand, wrist, and then you're procoagulable from static blood flow, then suddenly you've just increased your risk significantly of having a clot form.
Okay, good, thank you. Another thing I wanted to ask was, obviously private space industry is coming along, and space tourism and stuff, and I think we all know that the people going up to space with that are going to be nowhere near sort of the fitness level of astronauts. And even if there are screening programs, I feel like with the amount of wealth at disposal, people will maybe bypass that. How do you see us mitigating the chance of thrombosis if this is a real problem? And say, would our only options be sort of the negative lower body pressure thing, or would we think about, I don't know, anticoagulation regimes that we can stop before we return to Earth? Like, how do you balance that?
Yeah, lots of really good questions there. So it's all these things with any anticoagulation decision, as you go through medicine, you realize lots of things in medicine are risk benefit. In the private sector, these guys will often be very heavily reliant on standing on the shoulders of giants. They'll look at all the research done by international space agencies. And I think what this does is highlighted that there's probably is a significant need for screening. And at the moment, there's no national governance, whether Europe, UK, states, of if someone wants to fly in space, they can pay some money and they can, if they want to get a health screen, they can do. But this adds weight into having a standardized protocol. So there is a group, Parabola Ladies, there's groups around the world who are looking into formalizing this process, and whether this adds enough evidence to suggest that people who want to fly in space, as well as having, making sure your heart and lungs are working fine, do you need to have a thrombotic screen as well? Do you need to have, need to make sure, are you a smoker? Do you drink a lot? Are you active malignancy cancers, similar to the screening you'd have in hospital? Then would you have a standard thrombophilia screen just to make sure you're not prothrombotic as part of that screen as well, just to screen these out? And then individuals who fly privately can have an informed decision. It may not stop them, but they may have a URI moderate to severe risk of having a clot formation in space because you're a smoker, you've got XYZ in your blood tests. So that could be one potential thing. And I know lots of governments are looking at making it a national standard even for private sector, but that's very difficult to regulate, a government trying to regulate private industry. So it comes with its own issues there. And then anticoagulation, like I said, every day in hospital, every patient in hospital will have an injection of enoxaparin, clexane, some sort of low molecular weight heparin as part of their VTE prophylaxis. And then do you extend that if it turns out that microgravity is a prothrombotic state? Do we then just give prophylactic clexane or enoxaparin or low molecular weight heparin to all astronauts to reduce the risk of thrombus formation? But then you're going down the rabbit hole of, well, that's a massive, massive resource burden. You're going to have to take tens of thousands of doses to supply a crew of 6 for 18 months to Mars and back. You talk about your volume power conundrum of how much volume that takes up in the spacecraft, how much energy that takes, and how much power that's needed to get that on a spacecraft to go to Mars and back. And then you've, as we touched on earlier, you've got the risk of trauma as well. Even though it's prophylactic dose as opposed to a treatment dose, you're still increasing the risk of bleeding. So these guys get traumas, they bleed, and then that could turn into a hemorrhage depending on the level of bleeding. If it hits your head, intracranial bleeding, then these are life-threatening, life-changing injuries in space, in resource-limited setting that may or may not have an intensive care unit or surgical capabilities. Then, again, I think of worst-case scenarios because that's what I do in ICU. But you have to think of these cases that 6 people who necessarily aren't doctors, you are going to have to deal with potentially these complications. But again, there's lots of research going into it. I don't necessarily have the answers, but that's my thought process sort of behind the private industry and sort of how potentially we'd mitigate this in sort of exploration missions or in the ISS as well.
I think that Professor Raluca from Bucharest has a question. Raluca?
Yes, thank you, Thais, and thank you for the nice presentation. I've just read today an article regarding the differences in the risk of thrombosis, jugular vein thrombosis in microgravity simulation. Differences between left side and right side. It was an 2022 article. I save it but on office computer, and I'm asking myself if such a difference could be reliable or could be only by chance.
So is the question, is this clot found in this paper in 2019 just an incidental finding, or is it just luck that we found it, or do I think it's real?
There were found a higher incidence of clot on the left side versus right side, talking about the jugular vein. And it seems, for me, it seems to be a little strange because clotting factors in the same conditions are similar from my point of view. And no, I'm just asking mainly for myself, and I'm trying to understand which could be the factors. Could be rheological factors, could be the anatomical disposition, could be very delicate differences in local blood pressures, or only because of statistic results. I will send Thais as soon as possible the article to have a base of discussion. I don't have many details at this moment, but I've just read the article and I was very intrigued about.
No, I think I've read. I don't think I may have read that specific paper, but I do agree that there are some journals that have suggested that the right internal jugular takes a straighter path towards the right atrium, and that there are more anatomical variations on the left sides as it comes down and joins the subclavian before rejoining. So there's less good drainage potential on the left. You've got lots of different vessels. There's more likely to have turbulent flow rather than laminar flow, which increases static flow and things. So there is anatomical variation that could predispose. But there's also an argument to say that we've only been looking for this for a certain amount of time. There could have been significant more clots over the thousands, tens of thousands of man-hours of spaceflight that we haven't missed because we haven't been looking for it, and people have been asymptomatic, and we've mainly just got lucky finding this one. So you can, I think you can argue it sort of both ways, but I do take your point. It's a very sort of interesting question. I don't have a good answer, but I definitely think it's worth investigating. I'd be interested to read that paper.
And one thing that I was thinking about considering is that the cause itself, which is the exposure to microgravity, the environment of space microgravity, it will be there. So it will, in terms of treatment, when you, let's say that you are in space for, I don't know, a year or so, and then you have this the need to be treated for that for X number of days or months, but as soon as we stop, let's say, you are going still have the condition that triggered the situation or the clinical situation. So I don't know what to do. I think that it is my consideration is more or less what Tobias was asking, about what is what can we do in terms of should we have a prophylaxis, or should you just treat everybody? Because as you said, Lucas, as well, very, very wisely, for sure it happened before, and in my opinion, it's for sure that happened before. The cause for that is still there, which is this changing in blood flow and not just the direction, but the speed and so on. And so what can we do then? What is the best maybe treatment or prophylaxis that we can use? It's something that you cannot change what is basically happening in microgravity, So it will be something that I don't know. In any case, it is a huge concern, I believe. I think that Paul.
There's a question.
Yeah.
Yes, there are many things to discuss here, so we have time limits. First of all, the study group, so-called study group, is very limited. So you have one showman. They have discovered one thrombus in one person. The coagulation and anticoagulation is a very delicate balance also on Earth, not to say in space, and they didn't solve all the problems so far here. I read some times ago, there are a lot of changes, including in the blood composition and the rheology, the anemia of space and things like that. I don't remember exactly what are the modifications in the blood concentration and function of different components of participants in the coagulation cascade, the thrombocytes, the different other factors. If anyone knows if in space they have done ever a thromboelastogram to see what happens with the coagulation profile of so-called normal astronauts. And the last comment, indeed, as you mentioned, you send people on, that's now, they say Mars a few months now, then some plasma or nuclear engine, it seems 45 days. Anyway, it's a big problem. Where do you take so many anticoagulants? How do you tune the dose? Because the parameters are changing. So it's a very challenging subject. And one more thing about stasis. Stasis can produce a lot of things. What happens not only in the jugular vein, but what happens in the circle of Willis? Because you have a circle between the vertebrobasilar trunk and the two internal carotids. The blood is pushed from the heart, goes up and goes to the other brain vessels. But what happens in between the internal carotids and the vertebrobasilar? Because theoretically, at least, the perfusion pressure is the same. So it should be like an equal pressure on both sides of the connecting vessels. So theoretically, it should be no flow. Still, there is. What happens in space? I didn't read so far about studies on the circle of Willis in space. So it's a lot of questions so far. We don't have all the answers.
No, I think, and that touches on a good point. I think they'd struggle to potentially image into cerebral vessels, but internal jugulars and lower limbs, DVTs are easy to examine. But I agree, people could have small PEs or pulmonary embolisms, but they could easily also have cerebral sinus thromboses as well, which can be significant. These people can have potentially, not just have a headache, but neurology, seizures. This is all part of the venous drainage of the head. But again, the ability to image that with non-expert radiographers and sonographers on board could be extremely challenging, which I imagine is probably one of the limitations to performing those sorts of studies. They can be done on Earth in dry immersion tanks or headrest or head down tilt studies. Yeah, but I totally agree with your point there, Paul, that there are lots of significant other pathologies that could be there and they need to be imaged and investigated. But as I think the thing that this paper has done is thrown up a huge number of questions. It's not necessarily provided many answers, but it's definitely forced the space community to ask a lot of questions.
Well, thank you very much for your presentation, Lucas. I don't know if you still have more time. There is I think that is another question or comment from Raluca from Bucharest.
Yeah. More time.
Hello. No, it's not exactly a question, but probably it could be a point of interest for our group, for all our activity, because the predisposition to develop clots probably is not only related with blood quality and anatomical disposition and dynamics of the blood flow. I don't know exactly, but could be a specific, let's say, group of change in terms of endothelium reactivity. And I didn't read too many articles related with endothelial function change in microgravity. And of course, not only microgravity affects astronauts during space flight, but probably the endothelium behavior could be a trigger or could be a partner in this process.
I think, yeah, I would very much agree at that point. I think there's some research, or limited research, on obviously the effect of radiation. Obviously within Earth's magnetosphere, there's not much that we can do. There have been some in vitro studies of increased cancer formation and endothelial damage in animal models using surrogates of cosmic radiation and things. But I think, again, radiation is a massive factor in all body systems, but particularly in thrombus formation. As I was saying to Toby, if you add in prothrombotic state of static blood flow, radiation causing potential endothelial damage, that sort of wear and tear over time with increased radiation exposure once you're on the way to Mars outside the magnetosphere, or there's a particular solar particle event. And then you throw in someone having a trauma, injuring a finger, a bit of bleeding, hit the head, and suddenly these individuals, astronauts, are an extremely high risk of sort of clot formation. So I think endothelial dysfunction will play a huge part in lots of pathologies associated with microgravity, but I think it'll have a significant role. I think radiation and endothelial dysfunction will probably play a big part in sort of clot formation and risk, and one of the big risk factors, because that necessarily won't be treated with exercise, lower body negative pressure. You have to be a bit more big and clever of how do you protect individuals against that specific risk, which I don't think there's any clever ideas apart from sort of radiation shields at the moment.
Thank you.